Assalamualaikum and a very good morning. Thank you from me and also the team for having me here. So now let's dig into the topic of traction retinal detachment. As a retinal surgeon, I think all our wish for all these complex cases is to have a smooth surgery, safe post-op recovery, avoid any recurrence or sequelae. That means whatever we do during the surgery is at the back of our mind is to make sure that all these things will not happen again, reduce the failure rate, as well as to have a stable retina at the end of the surgery. So how do we deal with this? Let's see what are the good things or the best practice that we have to do before surgery and also during surgery. Now, before surgery, of course, we have been told many times we have to handle the patient's factor very, very diligently. Number one, their expectation. Number two is their medical problem. And once patient agreeable for surgery, then we move on to make sure the indication is very, very clear. The benefit should outweigh the risk that we are doing. Make sure the potential is also fairly quite good, and then prepare for the surgery by giving the anti-VEGF and also preparing the instrumentation. Now, when it comes to management of the patient, of course, we try to treat the patient as a whole. We always try to, because it's going to be long-term relationship with the patient, we try to talk to the patient and try to understand their social issues to make sure that they actually can complete the whole series of treatment, ask about their financial support, and always get the family involved. We also need to have a very good documentation. The reason being is because during the counseling session, we tend to tell patients a lot. There's too much of information. Basically, when we first talk to the patient, it can be very overwhelming for the patient. So I always get a family member involved, and trust me, sometimes they just tend to forget whatever you have informed them before surgery. So it's always nice to get more people involved during the counseling session, and make sure they understand the realistic expectation of the final outcome of the vision. Number one, we try to save the vision, but then we can also tell them, a significant proportion may have improvement of vision, but there are also patients from 10 to 20% of these kind of cases may end up losing some amount of vision by 1 or 2 lines. And also the failure rates might go up to 10 to 20%. Make them understand that they have to go through multiple surgery and they'll be absent from work. This is particularly important if they have both eyes involved. So there will be repeated close monitoring and also visits. So they have to understand that is what they are going to go through. Of course, their medical problem, we have to collaborate well with our physician to make sure they understand what they're going to go through. We need to make sure they have a good insight. That is the most important thing. Having a good insight means they will control their sugar better by taking the medication, and at the same time will adjust their lifestyle so that they can keep the sugar, the blood pressure, and everything under control, so that the patient will have a good and safe surgery as well as a good potential outcome. Now, we need to keep ourselves updated in most of the treatment, particularly for the anticoagulant. There are more than 10 anticoagulants in the market nowadays. You can be very surprised. They have all these fancy names. And there is this one meta-analysis talking about, based on 22 papers. And they did say that, patient with anticoagulant has a high risk of developing a persistent bleeding, as well as needing a second surgery. So if possible, of course, we want to try to omit some type of anticoagulant. It doesn't have to be all types. I still operate with patients on the aspirin, which is fine. Some patients could not off the anticoagulant because they just had their stenting or bypass surgery. So we can still do surgery, yes, but with a bit of caution, and tell the patient if it is too urgent that you can't delay the surgery. You really have to make sure they understand the risk, number one. Number two, actually there are a lot of good anticoagulant, a strong anticoagulant which has a very short acting, which means, for example, I just deal with a patient on Xarelto, multiple fibrosis, multiple thrombosis, and I was advised just to stop the Xarelto like 24 hours to 72 hours before surgery, and they will help me with the bridging. Bridging apparently is not necessary, but for some high-risk patients, they do prefer patients to be on the bridging. Now, when we look at indication of surgery, we do have several indications when it comes to TRD. Of course, when there's macula is involved. When we talk about macula involvement, we have at least two types of involvement, which means a clear separation at the fovea center, or number two, it could be just a displacement of the fovea from its actual position. When you do an OCT, you can still see there is no separation of the retina itself. So this macular dragging, I would say it is a bit underdiagnosed because it can be easily mistaken with the macular ischemia. Now, the reason why I say that is because those patients with macular drag usually have so-called a flat macula. On fundus examination, you can see the posterior pole is fairly quite flat, but then the vision is disproportionately very bad. It can mimic the macular ischemia condition. So how can we differentiate between those two? Because in macular ischemia cases, you know that the potential outcome is very, very bad. So we don't want to operate on those cases if you can see the macula is attached, but we do want to operate in a patient who has displacement of the fovea, or we call it macular drag. Now, how do we differentiate between those two? In patients with macular drag, when we do an OCT, you can see there's a loss of fovea contour. All right, where is the fovea? That would be the first question, because usually, even though they are detachment, you can actually see the indentation in the fovea. In this situation, everything is just straight. You can't see the fovea indentation, and if you do fundus examination, you can actually see the fovea is actually being displaced, usually towards the optic disc, because fibrosis is usually at the optic disc. When you do OCT in macular ischemia, this is what you're going to see. It's more or less a normal position of the fovea with indentation, but at the same time you see a lot of thinning and loss of the outer retinal layer. Case number one, I would say I'd like to share about this one of the case of macular drag case that we have. 50-year-old lady presented with 6 months of poor vision, 1/6 vision with a mild amount of cataract, and fundus doesn't look so bad, but the vision is actually very bad. So when we did the OCT looks like, now the question was, where is the fovea indentation, right? So it is actually towards the optic disc. So proceed with surgery, did a cataract surgery at the same time. She ends up by 6/18 vision at 6 months. So we did tell her, okay, I think probably this could be your best vision, but we never know because you had a displacement of the fovea before. However, she came back after 1 year and vision was 6/9. It does improve with time. So in macular drag cases, of course, we want to do surgery, but of course, not for macular ischemia cases. So try to identify when you see a case which has a flat macula, bad vision, is this a macular ischemia or is it a macular dragging? Now, when you have traction retinal detachment, again, people are talking about do surgery in threatened macular cases. What do they mean by that? When we have TRD with a threatened macula, as we know, TRD cases, pure TRD may remain stable for years. It can be up to 50-60% of them may remain stable for years. So personally, I think, of course, when you see threatened macula, is when the macula itself is not yet involved, but it's almost coming very close to the fovea center maybe. In that situation, if the vision is still good, patient is functioning very well, just keep a close observation and just wait and see. The reason being is two reasons. Number one, TRD cases can be very, very stable. Number two, because some surgery itself, even in a good hand, literature everywhere is saying that that there are about 10-20% of patients may still have some reduction of vision after the surgery. So I would say in a case of TRD, threatened macula is not an indication of surgery, right? Whereas in combined TRD, RRD, yes, you might want to go in early because the nature of when you have a hole or a tear, the progression will be very fast. So threatened macula is only indicated if there is sign of progression of, particularly in combined TRD and RRD. Now let's look into the surgical technique. Of course, when you are setting up a new institution, for example, it is very, very important to make sure you have all the instruments ready. Make sure you have a good staffing, very, very important, and also make sure you know your machine in and out. especially when you're a solo surgeon, when you are being independent. Now, when we do surgery, of course, we deal with all the traction, we have to deal with all the bleedings and tears, and most importantly, we are also should be capable to embrace all this new technology and new system. Now, when we deal with traction retinal detachment for surgery, yes, we do anti-VEGF quite routinely, LA or GA. I still do 80% subtenon and probably 10% doing GA, or probably less, depends on the situation. For instrumentation, we'll talk about it later. And again, in most of the surgery, I try to do single surgery unless the cataract is very significant, and unless if the condition posteriorly is not so bad. If it's going to be complex surgery, lens is not so bad, I tend to do the single kind of surgery and avoid combined cataract surgery. Now, which gauge is the best in these TRD cases? We have 23, 25 and 27. I do think 25 is still the best for TRD, for obvious reason. 23 is a bit too big, 25 is just nice, and especially with a bevel tip like Alcon, and the system is very, very stable. 27 gauge is good, but I would spare that for less complex cases, simple TRD cases, simple vitreous hemorrhage cases, which does not need too much of manipulation. And I still think 25 would be the best for this type of cases. Reason being is with 23, you still get some lowish IOP, less than 10, and obviously sometimes the gas still escape despite doing good wound, but you hardly get any escape of gas using the 25 gauge. So I think everybody, a lot of surgeons would agree with this, with 25 gauge system at the moment. Now, what is a special thing about this bevel tip? I think it's only available with 25 and 27. It is not available with 23. Bevel tip allow us to work in a very tight space because of the angulation of the tip, number one. Number two is because the opening is becoming very much closer to the end of the tip, so you can actually go underneath all this membrane, which is a very tight membrane, very close to the retina, and you can do all this peeling, segmentation without hitting the retina, right? Especially if the or the retina, underlying retina, is actually flat. And also, we love the stability of the system, whereby you can actually do the cutting and do the vacuum whatsoever, trimming the vitreous without having the retina to be flapping around so much. So it's not only about the tip, but also the system, which are very quite stable. Now, the beauty of a bevel tip, again, because it's very close to the end of the shaft, there will be an effective suction. You can see I was actually trying to cut the vitreous overlying the retina, but because the suction is very effective, it just sucks out all the pre-retinal bleeding efficiently. And also at the same time, because of its small tip, it is a very, very good dissector. So as now we are actually doing segmentation of the fibrosis. Okay, this one probably is not too bad because there's some space. Now have a look at this area. There's actually a folded retina there. So we are actually now overlying. As you can see, I was actually moving my shaft right and left to get into the space, and we can actually dissect well. This is actually the folded retina down there, and we can actually do the segmentation very, very well. Now, just to show how close you can work on top of your retina. Well, we don't really have to remove this membrane, but just to show that you can actually do your segmentation very, very safely without seeing any trauma to the underlying retina. It is always nice to be able to gauge the complexity of the surgery before the surgery itself. Don't look at the difficulty based on the amount of fibrosis, but look at the difficulty based on the amount of vitreous detachment. Now, as you can see in this kind of case, it doesn't look so bad on the fundus, but obviously you can see even the wide stream could not detach itself from the optic disc, and you can imagine most of the area probably is still strongly attached. So in this kind of situation, it doesn't look so bad on a funduscopy, but you might be able to gauge there's not much of PVD. Whereas in this situation, it looks very bad, but you can see, at least you can gauge, probably there's some separation here, some vitreous separation here, and probably some remaining attachment here. And the only part probably is going to be difficult is the membrane over the optic disc. TRD is the worst, I would say, among all. And sometimes you can get patient with a macular hole, which you have to deal with the ILM at the end of the day. And if you get cases with TRD and asteroid, it's even worse sometimes because they don't easily separate it. The vitreous is not easily separated in this kind of situation. Now, when you have these cases with very minimal PVD, this is what's going to happen. You can see that at the end of the day, we have to work very, very closely and try to remove as much as we can and as safely as we can. So again, this is just to show that you don't gauge severity based on the membrane, but pay attention at the amount of vitreous attached to the retina. Now another example, this one is not so bad. You have a bit more of separation. So we are cleaning up the vitreous gel, eating up, going into the subhylar space. You can see the blood, and keeping a very stable and good view. Do not have to go and suck out the blood even at the beginning. Try to keep the view good at all time. And I was actually keeping a bit of the AP traction behind at the moment, just so that I can do some delamination, putting my cutter underneath the fibrosis, overlying the optic disc, gently swiping my cutter. Make sure there's no tight space. If you feel any tightness, you might want to just stop and cut. Now this is still some kind of see-through membrane, so you may need to make sure you can see your shaft at all time, and you may have to make sure that you're actually on top of the retina, so you do not want to create any hole or tear within the folded retina itself. So you don't want to create you don't want to convert a TRD into a combined TRD, and at the end, this patient just end up with having a gas, right? Some amount of vitreous. Now when you have a TRD per se, it's not that difficult. Not to say it's not that difficult, but among all, it is probably the easiest because you have space, right? And you have some counter traction from the underlying retina, so maneuver is usually much more better compared to the TRD RRD case. Now the reason why RRD is not the same between the usual RRD is because it does not follow the Linkoff's rule. The RRD follows the Linkoff rule. It has almost a complete PVD, whereas a combined TRD RRD usually do not have a complete PVD, and the tear is usually hidden, so it doesn't follow any rule. You just have to go and find the tear, which is usually at the posterior pole. Now if you have a TRD RRD, you probably want to avoid doing this, because you don't have a counter traction. You may end up with a bit of tear and also bleeding, so we don't want to do this in this kind of situation. So instead of simply pulling like that, probably the best thing to do is to do the bimanual dissection. So this one we have to use a chandelier. One hand is holding the forceps and the other hand is using the cutter. Alright, and you can peel off safely without causing any tear and without causing any additional bleeding. Now let's look at, before we finish up, I have just about 2 minutes. I have this 50-year-old gentleman presented to us, 660 vision, and again defaulted after 1 month, came back, worse vision. It's almost like still kind of open funnel, I would say. It's just I can't see the optic disc. So we proceed with surgery because I know 1 month ago the potential is not so bad. It is bad, but there's some potential. So I told the patient, yep, the vision was 6/120, so probably you still have the potential, so let's go in and please do not delay this time. So we went in, removed all the gel. Obviously there was not much of PVD, and trying to find all the spaces. Now I am actually at the superior part, managed to get some small space there. and slowly swiping my what do you call it, swiping the cutter, and cutting off the traction. Now there's another attachment there posteriorly. I was repeating the same thing and cutting off that traction. So that was one, and proceed with the inferior bit, proceed with the more anterior bit, and finally using the bimanual separation. I managed to open up with a bit of heavy liquid, controlling all the bleedings, and I use a lot of heavy liquid in these type of cases. You don't have to drain the fluid too early. Keep it as part of the indentation effect, and I love tunnel very, very much. Stain a bit, look for all the vitreous schisis, and make sure you clean up all the gel 360 degree. And keeping heavy liquid is good so that you have the counter traction. So you can see I was moving my tunnel, swiping up. It's like swiping the floor, getting rid of all the remaining vitreous gel, a bit of blue. I just love playing with all this staining. And slowly again walk on the retina for the final stage before he close up. And post-op 3 weeks, he managed to get at least 260, so hopefully he will continue to improve. Now this is what we call an additional instrument for all the complex cases that we do: stain, heavy liquid, tunnel scraper, cannula, solid illuminated laser. If you don't clean up the whole gel nicely, we might end up like this, especially if you put a silicone oil in the patient's eye. If you have any dealing with heavy liquid for bleeding, you might want to use this, clear up all the blood, and eventually able to do surgery nicely with a good view. And finally, I think this is one interesting part as well, to use your reflux mode button so that you can actually wash away the blood from the surgical area. So I like to put in all this dye at the beginning of the surgery because we get the contrast, so it's very nice. And it gives you a very nice contrast. So this is just an example. You can actually use your reflux button and not this one. Very shortly you will see that we are actually refluxing away, pushing away some of the blood. There you go. You can see that we are actually doing that cutting mode. Once in a while you put on the reflux button, and you can see that you go washing the blood away, so that you can see the space and also the membrane very, very clearly. Sometimes we do eyelid peeling. If the retina is flat, it's much easier, but if the retina is detached, you might need the heavy liquid to help. Okay, it is very challenging, but of course it is rewarding before and after. Some of them can do quite well, and finally, some of the cases, it might look very bad at the beginning, but with diligent involvement of patient as well as the doctors, I think we can end up very well. Thank you.